Hello. The title of my talk is At Scale in the Real World. And what I aim to discuss with you in this session is really some examples of real world evidence-based interventions on hypertension care that we've scaled up and are really being implemented in the real world settings, in a number of them in low and middle income communities, both in largely in low and middle income countries and some in high income countries in the primary care settings. And we've used state-of-the-art implementation frameworks. Just to give you a brief background of why we are talking about, let me enlarge this here. Okay. So give you a brief background of why focus on hypertension, cardiovascular events, and mostly on low and middle income countries. Here are the figures showing you the rising burden of hypertension. It's beyond the scope of the talk to go into much of the details as far as the barriers are concerned. But suffice it to say, I mean, it's a lot to do with the socioeconomic, political, and environmental factors which relate to including poverty, food insecurity, especially low education, and low employment with low socioeconomic positioning and stress. The stress plays a big role, both through biological mechanisms and pro-inflammatory mechanisms, but also behavioral mechanisms, because stress leads to emotional eating and taking up unhealthy behaviors such as smoking, and which again gives rise to your premature cardiovascular disease, especially when there are weak health systems and are not able to evaluate quickly or initiate treatment quickly. So lack of preventative medicine, compounding the issue. And so and premature death and are manifested of course in the health system as patient level barriers, provider level, and systems level barriers, because lack of standardized care, underfunded health systems, and so urgent solutions are therefore needed, but they are obviously going to be very complex and not straightforward because of these large contextual social determinants issue. So how do we address these problems? It's not going to be one single solution or single intervention, clearly. And we've attended to some of these and developed these. I'm going to give you the example of our control of blood pressure risk attenuation trial and the journey, which really started, as you can see here, almost 25 years back with the COBRA feasibility study. And COBRA stands for Control of Blood Pressure Risk Attenuation. Our journey started in urban Karachi, which is a metropolitan city in Pakistan, where we first did a feasibility study for these and developed these interventions, and then evaluated that as a proof of concept study and effectiveness in the urban setting. And then when we showed that they worked, evaluated them for a scale out in the rural areas in Pakistan and in other countries, Bangladesh and Sri Lanka, which then became the COBRA BPS study for evaluation in the real world. And you can read more about it in the papers, and assess its acceptability is currently being scaled up and scaled out in other settings. And I will share this with you. And all along, we've involved our advisory committees, international members, health planners, policymakers, and I'll be using that the STARI framework for reporting this. And to develop our COBRA strategies at that time, early 2000, many of the frameworks, as you know, theoretical frameworks for developing and implementing and evaluating interventions have evolved and are being refined, every day. A newer, more rigorous framework is developed. And about, almost now 25 years back or so, when we were starting to develop COBRA strategies, it was the MRC framework and the earlier version of this that was used in the early 2000s, which is what we use for complex interventions to develop the COBRA strategies. And using behavior change communication strategies in this. So the goal at that time when we developed the COBRA was to develop an effective, cost-effective, and potentially scalable. We were always into developing a potentially scalable intervention that was scalable in the real world for hypertension care and low-income communities. So this was a cluster randomized trial, and at that time it was like, gee, how is going to be, this is such a complex problem, as I just shared with you. How do we address this? And so we were in discussions with the stakeholders. We said, well, in a situation analysis, what's there? And the health systems were really mixed health systems, but what was there was good maternal and child care still. And there were these lady health workers who were going door to door delivering maternal and child care. And we said, well, why can't we use that infrastructure? And it's always wise to use an existing infrastructure. And we knew from there was a lot of literature coming out on interventions that would work in an individual setting in the clinic. So for DASH diets, other interventions on medications. So guidelines were there, but then implementation of them. And so we we reasoned that the same community health workers who were delivering the maternal child care, perhaps they could be trained to deliver the home health education using the dietary approaches to stop hypertension, which is what this was based on, using behavior change communication strategy. So that was one intervention. And the second was the physician's knowledge was really poor, which was our work had shown. And then we said, well, how about we train the GPs in updated management and updated guidelines, which at that time was JNC 6. And the BHF, the most updated at that time guidelines. So we developed that curriculum and we designed it as a factorial design, as you can see here. And what we found, and so this is a community health worker who is going door to door, as you can see here, and checking the blood pressure. And this, you can see the level of poverty here. They don't even have a table in Pakistan. And this is the dietary advice, the DASH type diet. And so, fruits and vegetables, adherence, and lowering salt, being physically active, and strategies on coping strategies, stress management, which again is a critical element of our intervention. And so what we observed was the combined intervention was really effective, the single one compared to usual care. There was also an interaction between the two components of the combined intervention. So clearly that worked. So with we are calling this like an efficacy proof of concept effectiveness study. We showed that it worked. We also evaluated its cost effectiveness. But then this was done in an urban Pakistan. These community health workers that we evaluated were sponsored or paid for by the trial. We did not know, some questions were unanswered. Well, how would it work when we use this in a government setting? And so would it dilute the effort? And what is it going to happen when we try it in other countries? So you can call it scaling out, because now we were going into different settings and we were going to be using the government community health workers. So how was it going to go in different kind of populations, and kind of little bit of a different setup. So scaling up and scaling out. And so and we were in predominantly urban areas. How would it do in the rural areas? So those questions we wanted to evaluate, and therefore we went in the rural areas. We first developed, again, like I said, we used the contact, we refined the intervention, adapted it, assessed the barriers, facilitators, feedback, and developed our COBRA BPS. And at that time, our goal was for the 3 rural areas, develop the strategies to deliver these strategies using public health infrastructure in rural communities across South Asia. So we wanted again to develop adapt this COBRA to a generalizable model for the real world. And those 2 components then become, after the extensive engagement, stakeholder feedback, feasibility study, became this multi-component intervention, where in addition to the 2, we included a triage counter and a financing model to compensate for the additional health work. And you can see that this is addressing each of these barriers: patient-related barriers, physician-related barriers, health systems-related barriers, and you can read more about it in the papers that are cited here. And so again, this was a cluster randomized trial in 30 communities in the three countries. And here, this is a physician in Pakistan. This is home health education being delivered by community health workers. Most of the community health workers were women, but there were some men, for example, in Bangladesh. And as you can see, when they were delivering home health education, the entire family would surround. And so would be a lot of dissemination and to not just the individual who has hypertension, but their family members, including children. And I didn't although show you in the interest of time, but we in the Cobra in Pakistan, we also showed that the effect that the blood pressure levels of children and individuals who are non-hypertensive were also improved. So there is definitely a spillover effect and benefit and all family members. And this is again this photo on the right lower corner is a public health midwife visiting the home of a patient in Sri Lanka. So this is again happening in the real world. And we found that the implementation fidelity, again, I won't have time to go into the details of each of was outstanding, was excellent for all components, except for the one component where we said the patients will receive subsidy after means testing. The districts couldn't do that, and so that element we've removed. We are not advocating for, but for everything else, the intervention fidelity, implementation fidelity was outstanding. The checklists that they were received were also very, very good for both from the community health workers and the physicians. And we did that using the REAIM evaluation framework. For a primary effectiveness outcome, we saw that the blue line is for blood pressure, systolic blood pressure intervention, red is for control, and you can see the blood pressure change in systolic blood pressure there was a much greater decline, greater by 5 millimeter mercury in the intervention control compared to the control, and similarly it was much significantly improved in the diastolic blood pressure. And this 5 millimeter difference will project about 20% greater reduction in cardiovascular morbidity and mortality. We conducted a cost effectiveness analysis, and this intervention was cost effective in each of the three countries. We did a budget impact analysis. Much would it cost? And this is working with our health economist, Sarah Finkelstein's team. How much would it cost if this intervention were scaled up in each of the three countries at the population level? And it would really cost less than $2 per person, per capita. And which actually serves as a best buy, qualifies as a best buy according to WHO. So clearly a cost-effective and affordable intervention. We did a post-intervention acceptability, and it was liked by all the stakeholders. Community health workers said that there is a definitely increase in workload, but they were enthusiastic because we'd given them the on rounds, and the feedback we received was that their social status of these women who were going door to door measuring blood pressure of men and women, the social status was elevated in the community because they felt like, gee, the community members are now coming to us, they're asking us to measure their blood pressure, they're now listening to us. And so that they felt rewarded by this. Patients were grateful, physicians felt trusted. So this was very positive. The Cobra BPS now, these interventions are being disseminated extensively in each of the three countries. I don't have a full, but this is just to show you a brief sort of overview that in each of the provinces, we are actively engaged, in each of the provinces in Pakistan, in Bangladesh. There's an active dialogue. Our site PIs in each of these countries are working here. You can see the dialogue with the policymakers. It's very active engagement at all levels for active dissemination and scaling up and integration at the district level. It's happening district by district gradually, and that's how the scale up is happening within the countries, and also in Sri Lanka in collaboration with the World Bank. So not only in the countries, there's also scaling out where we are adapting Cobra to improve hypertension care. Nathan Tillman and Julian Hertz are our collaborators based at Duke who are working in Tanzania when the HIV infrastructure with the HIV clinics to integrate Cobra with the HIV infrastructures. They have a grant from the Fogarty and working on that. So that again, we'll see how that, and very positive feedback again. So that was about the low and middle income countries. Very briefly, we have a program in Singapore, in the primary care clinics in Singapore, where again, blood pressure control rates are a lot better in high income countries, but still there are a lot of problems with population in the lower socioeconomic, and we are actively engaged throughout the health planners, and there's a roundtable conference, in fact, scheduled next month for discussing scale up across all primary care clinics. So in short, yes, you can see these with these examples that the multi-component interventions, our summary is likely to translate into substantial reduction in premature deaths. In low middle income country settings, we've used a community health worker led model. In high income countries, it's a different type of team-based care with the standardized multi-component intervention. But the ease of adaptation of these models, where we've worked with leveraging the existing health infrastructure and the rapid scalability of these interventions, would be a rapid step forward for reducing hypertension rate, morbidity, and mortality. Well, what lessons that we've learned in these real world interventions and large scale implementations are some very important lessons. Is that one of the things that really helped us a lot throughout, and we worked with the public sector clinics, public sector communities, programs with the lady health worker programs and others, and working in these districts, is one key thing was community buy-in and community engagement. And I don't think that we could have gotten. We are working with countries like Bangladesh, Pakistan, Sri Lanka, where during these couple of decades of work, we've experienced a lot of issues with floods, with political uncertainty, conflicts, other issues. But our projects and our interventions have been successful despite all of these challenges. And one of the things that has been with us is the communities buy-in, community engagement, and leveraging the existing infrastructure and existing resources, which keeps it going. The other thing is the buy-in is when you're designing the intervention, some of the things need to be in the intervention, such as the task shifting, you have to empower people. So I shared with you the example of empowering when the community health workers said to us, gee, you give us the similar kind of empowerment we felt with the nurses in the Singapore clinics, who felt rewarded when they called the patients and got very positive feedback about perceived effectiveness of what they were doing. And so I think it's not just the monetary rewards, but it's also other types of rewards, and making them work at the highest level of their credentials and qualifications. I think those things are important, and getting their feedback throughout, having regular meetings, and building them into the intervention. So it's the characteristics of the intervention, you're designing them, and you're thinking about scaling up and saying, well, how do I keep the people engaged, empower them, and give them ownership of what they're doing, and then realize in them the importance, and they receive the feedback and perceive effectiveness. I think those are really important things. Then the integrate social determinants. And I think this is important for the people who are receiving the intervention. So they have to see a lot of times, it's not just they have to be heard. And this way, I think the coping strategies and the motivational conversations were helping. The behavior change communication strategies were helping when we are dealing with we're going in areas that are poorest of the poor. And I think the population was feeling heard and creating referral mechanisms, which sometimes go beyond the trial a little bit. But I think the idea here is the teamwork and doing and creating networks. And I think that those will happen in community to community, but they are important and they are key. And then the political will and engaging policymakers. And so there are some politicians who will always deny the problem. They deny non-communicable diseases. That will happen. But there are always people who are all going to be listening. And so keeping them engaged and informed, sharing policy briefs and listening to them will help. And it's the continuous engagement that brings people to the middle ground. And then monitoring implementation fidelity as part of the intervention is important and is key. And that will be, again, part of it is done through regular meetings. which is built into the intervention. So I can't underscore this enough. And that's why people learn from one another. We had a lot of learning among the communities, and often one community would face a challenge, another community would teach them, this is how you navigate this issue. And so there is a lot of innovative navigation that happens through working together, and sharing of issues. So meetings and monitoring implementation fidelity and sharing it, and also equity is here important, that we find out issues early, and so build them into the design of the study. And lastly, factor competing priorities during planning. So things will happen, natural disaster will happen, floods will happen, other things will happen. We had a lot of polio campaigns, other floods, things happen. So built in some leeway, and it's just not to give up, and work again. If we are in the community, we work with the community members, and they know that we are there to stay, and we are continuing. We continue to be in the communities. We are also trying to use digital health where it's available. One experience that we have is that people, although like and appreciate the digitalization, they still want the human factor. So a hybrid kind of thing, as we are scaling up Cobra and other interventions, we do advocate strongly, especially when we are going into these communities, to not lose the human touch and human factor. I'm going to stop here. And before I stop, I just want to acknowledge all members of the Cobra BPS team, and all participants and collaborators, stakeholders, and of course of the Sing Hypertension team. And thank you so much for listening. Appreciate it.